Q&A tab at the bottom. And so, you know, if you, there's Dr. Allen. Good morning.
Morning,
I had to
Carl.
find my ask word. Sorry, I'm a little bit late.
No worries. No, great to see you. Thank you. We're just kind of walking through a brief run through of the session. So Glenn Liu will be serving as moderator. He will be the only one that needs to be on camera when the session opens, and he will just sort of intro you and then therefore go right into the video. If Dr. Allen, you and Glenn can just keep an eye on the Q&A tab at the bottom. Glenn, minimally, if you can sort of compile those or prioritize those as you want for the live portion at the end. What some of the speakers did yesterday was during the playback of the video, they actually went in and started responding to some questions via writing in the actual tab. So that's up to you if you're comfortable with that. Otherwise, Glenn can facilitate sort of the verbal portion. And then at the end of the video,
my name is Glenn Liu, and from the Aflac Cancer Center at Emory, and I am happy to be moderating today's session called Disorders of Leukocytes, presented by Dr. Carl Allen from the Baylor College of Medicine and Texas Children's Hospital. I do have a few announcements before we start. Please don't forget to network with your colleagues in the chat box at the bottom, and also utilize the Q&A feature if you want to ask the speaker any questions. If you see any questions that you would like to see answered, you can also vote on those questions to raise it on the priority list. At the end of the presentation, there will be a dedicated live Q&A time. If you experience any issues viewing the session, please try refreshing your screen or visit the support tab at the top of the screen. And so now I will turn it over to Dr. Allen.
Children's Hospital, Baylor College of Medicine. Okay, hello and welcome. My name is Carl Allen from Texas Children's Hospital, Baylor College of Medicine, and I'm happy to share with you a talk on disorders of leukocytes as you prepare for your pediatric hematology oncology boards. For a few disclosures that aren't relevant to this talk, but I have some involvements with Novimmune on their Gamifant studies, as well as consulting for Roche. But again, none of this is relevant to the topics I'll be discussing. Further, no drugs I'll be discussing are approved for pediatric hematology oncology. I also want to make a big disclosure that I'm violating a lot of the rules I have and advice I give to fellows for giving talks, which is I'm really packing quite a lot of information in these slides, really teaching to the test. So I really see this talk more as an orientation to a study guide than a typical talk. And my goal for the next hour is going to be really to orient you to this tool. I also want to point out that as you're prioritizing your time, leukocytes are listed as 4% over the overall board review, or rather the overall board test. And there's a whole lot of minutia packed into this topic of leukocytes. So I've tried to highlight certain sections. So if I have something that's red, I think this is something that's pretty high yield to show up on a test. So pay attention to those sections. All right, so with those disclosures, I'll go ahead and get started on the talk. So here, this is a really oversimplified hematopoiesis diagram, but I think it helps us to understand the different types of cells we're dealing with and the different types of diseases that result from dysfunction of those cells. So today I'm really going to be focusing primarily on the neutrophil, although this whole area of sort of myeloid differentiation, I think, is fair play. Ken McLean is talking a bit more about macrophages and dendritic cells in the histocytosis section. And then any malignant conditions will be discussed elsewhere. Further, I believe Dr. Pai is talking about disorders of lymphocytes. I'll touch on those only very, very briefly. All right, so for part one, we're going to talk about granulocyte function. And I just wanted to highlight the historical importance where good and laudable pus has been described as differentiating on sort of Greek and Roman battlefields, a wound that has potential to heal versus a wound that's less likely, a more necrotic wound. And so it's been recognized for quite a long time that something about this early process within the wound is quite important. As I talk about the function of the neutrophil here, a lot of the early discussion is going to be sort of basic mechanistic biology of neutrophil differentiation and function. And again, I think a lot of those esoteric biology components aren't necessarily going to be tested on the boards, but they're important to frame what happens when those parts don't work, as we'll talk about in the subsequent sections of the talk. All right, so the neutrophils primarily are responsible for innate immunity. Innate immunity means responses that are present at birth. They aren't learned in response to exposures to specific antigens. So we're hardwired with these responses. And so it's really important because bacteria reproduce within 30 minutes. And if an adaptive immune response takes weeks, it's not very effective to tackle an early infection. So phagocytes, and including neutrophils, respond to pattern recognition receptors, or PRRs, and these PRRs recognize pathogen-associated molecular patterns. So viruses, bacteria, fungi, they all have specific shapes that are conserved that are recognized by neutrophils and macrophages that don't require adaptive education. So this activated innate immune response results in this clinical information, or this good and laudable pus that was described centuries ago. So with innate immunity, what happens? So first we have this infection or tissue damage. And when you have that tissue damage, you activate toll-like receptors, you release certain kinds of lipids, chemokines are released that alert the neutrophils to come into action. Complement is activated and coats the offending germs and bugs. Kinins are activated to modify the endothelial leakiness to let the white blood cells come through, and then certain coagulation proteins are also expressed. And what happens then is you get this with innate immune response, you increase the vascular permeability, it allows the emigration of the phagocytes, and then ultimately you also get an adaptive immune response following the initial innate immune response. So again, the neutrophils are the Marines of the immune system. They're sent immediately when there's an alert. So they're first recruited to sites of infection. These are the most abundant circulating phagocytes. So again, there's macrophages and some other and dendritic cells and some other phagocytes we'll talk about later, but neutrophils are the most common. They're attracted by cytokines and chemokines. We'll get into these mechanisms a little bit. Once they're attracted to sites of infection, they are alerted to cells that need to be cleared that are tagged with complement and antibody. Once they recognize the complement and antibody, they ingest their microbes and they kill them through a NADPH mediated reaction. Okay, so first of all, in order to create this response, you need to recruit Marines. So how do you do that? How do you grow and train these cells? And so, we have our stem cells that are able to give rise to a huge host of the white blood cells. And then we'll preferentially grow neutrophils with a variety of growth factors. And I think the ones that are most important really are GCSF and GMCSF, but again, primarily GCSF, right? This is what we send everybody home with after their chemotherapy so they can increase the low neutrophil count that results from our iatrogenic therapies. So for granulocyte homeostasis, it's important to understand this, to understand why different strategies worked for us to be able to create more neutrophils or to recruit neutrophils to sites of damage. And so again, our bone marrow makes neutrophils based on influence of GCSF and GMCSF. But then once we have these mature neutrophils, we have both a circulating pool, which is actually quite small, and a marginating pool, which sort of sits in tissues, kind of waiting to be activated. And then once you have tissue damage, we kind of mobilize these different compartments to be able to recruit to the tissue. And I think this is really important when you look at the percentage of cells and how long they last. This really gives us an idea of how we can take advantage of mobilizing neutrophils and what kind of problems we might have at different stages of differentiation. So of course, we have our bone marrow precursors or stem cells. And so we start making sort of this steady drip of neutrophils based on typical growth factors that can be increased under certain conditions where more neutrophils are needed. But this is really a very tiny fraction of the granulocytes. And then within the bone marrow, we get the bone marrow precursors. We go from stem cells to myeloblasts, promyelocytes, myelocytes, metamyelocytes. So again, these make up an increasingly large percentage of the cells that ultimately become granulocytes. And then most of these mature neutrophils, the bands and the segmented neutrophils, are going to hang out in storage compartments like the alveolar compartments, et cetera. And then if they're called into action and mobilized, really these cells really last about only 9 to 12 hours and represent a very, very small percentage of the total granulocytes. So only about 5% of our neutrophils are included in sort of the action of clearing infection. And then over about a 24-hour period, they're cleared through apoptosis. So these are all the different processes through which a circulating neutrophil is drawn to sites of infection, at least the most significant components of this process. And as I go through each of these components, we'll follow up later in the talk when one of these parts is missing, what happens? Because I think that's a lot of the diseases that you'll be quizzed on for your test. All right, so what we have here is 2 to 3% of the neutrophils that are in your blood, kind of that we record in the absolute neutrophil count. They're kind of minding their own business until they come across chemokines or cytokines. They recognize them with the chemokine or cytokine receptors. And then they start, what that does is it drives them to the endothelium. And the endothelium, you have these receptors, such as the sialylated carbohydrate receptors that interact with some of the integrins and integrin receptors on the endothelial surface. And these really start making the cell slow down and park. And then they start getting drawn again through chemokines and chemokine receptors to kind of crawl through the endothelial membrane. And then as they go to the sites of infection, what you see is these germs get tagged again with complement, activated complement, as well as antibodies. When they recognize those germs, they engulf them. Once they're engulfed within the phagocytic compartments, then you undergo sort of this NADPH mediated oxidation that leads to creation of bleach that kills the offending pathogen. So that's really the process. And then we'll go through the specific ingredients that make up each of these components, and then talk about the pathogenic implications when they don't work. So again, so we have these various functions. So the first function of rolling or adherence, again, we have these cell surface proteins that are sialylated. We have L-selectins, we have beta-2 integrins, and we'll talk, it's really important to talk about the CD18 and the CD18 partners that make up the beta-2 integrins. And so these different components on the surface of the neutrophils then interact with the endothelium. And you have these plasma membrane associated receptors. We have granules containing stores of receptors as sort of backup parts. So if you need to kind of create more of these components on the cell surface, these get released to the cell surface. And then we also have actin and cytoskeleton accessory proteins that mediate the actual diapedesis or rolling and adherence. All right, for the chemotaxis, what draws cells to the germs? So we have complement, we have lipids, we have various chemokines and cytokines. So again, this is going to be mediated by plasma membrane associated receptors. It's going to have actin, cytoskeleton, and accessory as above. And then we also have various granules and glycolysis required for these activities. So for the function of ingestion, again, we have these antibody receptors, the Fc gamma receptors that bind the antibody. We have the beta-2 integrins that can recognize and bind complement, and then we also have specific complement receptors. And so again, these are plasma receptors. They require actin, cytoskeleton, accessory proteins, and they require energy. And then for the degranulation and killing, so once they're engulfed, you get sort of this this is downstream of chemotaxis and ingestion. This really are all the different killing properties. So all the different enzymes and again, the process required to create hydrochloric acid, as well as some other specific killing mechanisms within the phagosomes that I'll talk about a little bit later. All right, so let's talk for a second about selectins. What are selectins? So these are cell adhesion proteins that bind carbohydrates. So these are very special in that they're different than other types of proteins and modified proteins, and that these are sialylated, fucosylated carbohydrates carbohydrates that sit on the cell surface. And so the different kinds of selectins can be described by where you find them. So L-selectins are on leukocytes, so you can think of them as L-selectin. And again, these are involved in lymphocyte homing and inflammation. E-selectins are on endothelium, again, part of inflammation. And P-selectins are on platelets. All right, so some of their binding partners include beta-2 integrins. So again, CD18 is going to be really, really important. And I'm going to talk about that a little bit in the future. And so the different kinds of beta-2 integrins depend on their binding partner. So for example, you'll have CD18 binding with with CD11A that makes up this LFA1 that's on all leukocytes, and that binds ICAM 1 through 3. You have CD11B coupled with CD18, which will bind multiple ligands. And this is really a little bit more specific to neutrophils, monocytes, and macrophages. When the partner is CD11C, again, this is monocytes, macrophages, and a few lymphocytes. And then when you bind with CD11D, again, this is monocytes, macrophages, but then also some T cells. I don't know that you would have to really memorize all of this other than remembering that CD18 binds with various partners of CD11 to make up the beta-2 integrins. All right, so here I'm going to talk about granulocyte differentiation. So this is the process through which the functional neutrophils are made. So within the bone marrow, we have our mitotic compartment with our myeloblasts, our promyelocytes, and our myelocytes. And you'll review this differentiation process, I believe, during your hematopathology talks. And this has a lot of relevance when we're talking about the different kinds of leukemias. So when AML is created from these different stages of differentiation, when they go off the rails, these different stages become important. I think for the purposes of benign hematology, it's really more important to understand the process that, in general, that you go from myeloblast to mature neutrophils through this mitotic compartment in the bone marrow, and then the post-mitotic compartment that includes cells in circulation. And then throughout the different stages of differentiation, you have development of different types of your sort of toolboxes of cell killing. So your eosinophilic granules come early, then your specific granules, then your tertiary and secretory granules. And I'll talk about what all those different things do in the next couple minutes. All right, so your earliest eosinophilic granules include proteinases and lysozymes. So these really are chemical or proteins that just kill other proteins. And so these cause degradation, digestion, destruction. And then you also have defensins and myeloperoxidase. So the defensins and myeloperoxidase do require oxidase-dependent killing. And the secondary specific granule, you'll have lactoferrin, transcobalamin, which binds vitamin B12, lysozyme, plasma membrane proteins, and cytochrome B558. You have to memorize all this stuff other than just to remember the different types of things that are included in the different granules in general. And then once you get to the more mature cells, you have these tertiary granules, then you start getting into the different components that can bind the pathogens, right? And so they carry sort of these spare parts that can get mobilized to the cell surface as needed when a cell is activated. And then the secretory components really contain just a lot of the different plasma membrane protein parts as well. All right, for antimicrobial mechanisms, how does this all work? And so I think the important thing to remember is just that these processes require energy, right? So one of them is an NADPH to NADP oxidation pathway, and then myeloperoxidase, and then together these two reactions lead to creation of acid that can kill pathogens. All right, so having said all of that, we're now going to talk about some of the different diseases that result when some of these processes go awry. So for this next section, I'll talk about what happens when you don't have enough neutrophils. I'm going to sprinkle a few pop quizzes here. When I do this in person, I like to call on people to make sure everyone's still awake, but it's not going to happen here. So we can do this virtually. So a 13-year-old presents with lymphadenopathy and ANC of 900. So what's the most likely diagnosis? So whenever you get the most likely on your test, usually this is going to be pretty obvious. And, I think the vast majority of neutropenia is just caused by viral illnesses or different kinds of stresses that we all experience. And are far less frequently malignancy. So how do we categorize neutropenia? So neutropenia is defined as being lower than normal absolute neutrophil count. So, and remember your ANC is your bands plus your segs. So your ANC really varies with a lot with age. So remember that when you're looking at your normals, and I think most of our hospitals now create these normals electronically. So remembering you're born with quite a lot of neutrophils, it then decreases over the first couple weeks to years of life, then it kind of increases. There are a lot of ethnic differences. And so, a very typical test question is that you have an African-American teenager with an ANC of what's wrong with them? And the answer is nothing. That's just variation that we see within different populations. Also, there might be a question about someone lives in Denver and their ANC has dropped from when they were in Houston. What happened during that 6-month period? And again, you get a lower ANC the higher you get in general. And then we have our different grades of neutropenia. So, if you're somewhere between 1,000 and 1,500, it's really not a big deal. Mild neutropenia, 500 to 1,000. There might be some minimal effects from that. Moderate neutropenia, I think this is the number we typically tell our patients to be careful at is 500. And then once you get below 250, then you get really a much higher risk of developing severe infections. So how do we evaluate someone who shows up to our office or in a consult with neutropenia? So I think the history really tells us a lot. Both the duration and periodicity, the trend over time. Is this a one-time thing, or is this something that happens over and over again? And again, I'll get into cyclic neutropenia a little bit later, which is something that's very testable. Have you been exposed to anything that would cause your neutrophils to respond? Have you been exposed to any kind of infections? Is there a family history that suggests something's showing up? And then on physical exam, you'll look for anything that gives a hint of syndromic issues, of infectious challenges, of ongoing infections. And then again, are there any other factors suggesting there's something more going on here than just the neutrophils? And then for lab evaluations, just the typical evaluations, you go to UpToDate and see recommendations to just get a CBC and a differential. And so if this is an ongoing thing, you want to do it twice weekly for 6 weeks. This is really to check if someone has cyclic neutropenia, or if they have steady neutropenia, or if they have progressively declining neutropenia, or if they're recovering. Peripheral smear is always helpful to get the big picture. Quantitative IgG, A, M, and E. And I specifically make sure you check for E. Sometimes that doesn't show up in the order sets. If this is really persistent or concerning, a bone marrow is helpful, as are chemistries to give the bigger picture of what's going on with the patient. If we're still being puzzled and we haven't found a reason for the bone marrow to not be functioning properly, looking for anti-neutrophil antibodies can be helpful. Doing viral studies, checking the overall nutrition of the patient, pancreatic function, because there's some conditions I'll talk about associated with pancreatic deficiency. Similarly, there's some bone disorders associated with low neutrophils, so skeletal radiograph, looking for autoimmune disease. And then I think something that's becoming more and more useful is just doing whole exome sequencing as soon as you've done a few of these initial tests and nothing's shown up. And I won't necessarily get this whole panel for every patient with neutropenia, but these are the sorts of things one could do depending on which direction the disorder or the symptoms point you. All right, let's talk about different causes of acquired neutropenia. So this is a huge, long list. It's not really, it's not exhaustive, but it just gives you an idea to think about when you're presented with a question. A child presents with neutropenia. What do you, what's the cause? And so we want to think about all these different things. So again, infection, the most common things. Drug-induced is an important question, and certainly we see this in our patients, for example, who have Bactrim or who are on penicillins, for example. You can see both specific toxicity against stem cells as well as cross-reactive antibodies. And again, speaking of antibodies, we have alloimmune, autoimmune, and isoimmune issues that can hit the neutrophils. If your bone marrow is not working, there's a whole lot of reasons for that. One of them is malignancy. Also stem cell failure because of iatrogenic reasons, because of inherited or acquired stem cell problems, vitamin deficiencies. I don't think you'll get this question, but during pregnancy, you can get impaired myeloid proliferation. And then of course there's idiopathic. We just don't know why your myeloid cells aren't working. And there's a couple weird ones that are worth noting, I've included here paroxysmal nocturnal hemoglobinuria. Just remember this is an acquired stem cell defect with the PIGA gene that might show up. And then also mechanical activation. When kids go on ECMO, bypass, et cetera, that can really change the stored neutrophil population that can lead to systemic inflammation. So infection is the most common cause of neutropenia. This is really important. This will definitely be tested. It's generally in the acute setting. It generally resolves within days to months. So the answer is very frequently support the patient, treat infections, and if you need to, give GCSF. And then a lot of the different common infections include the herpes viruses and other things I've listed here. Rickettsia, malaria, leishmaniasis, histoplasmosis specifically cause low neutrophil count. These are not very common infections, but they're highly testable, which is why I have here. And there's a lot of mechanisms. You know, the neutrophils get consumed. There's complement-mediated margination, suppression, et cetera. That can, a lot of different factors that can lead to neutrophils being consumed and as well as not made. There's also drug-associated neutropenia. So this is relatively rare in children compared to adults, but you know, if someone's on a new drug, they develop neutropenia, stop the drug. In some cases, they need GCSF. As I mentioned, you have immune-mediated, so the penicillins and cephalosporins can cause autoimmune issues. Some others, such as Bactrim, can cause specific toxicity to the stem cells. And then you can also get hypersensitivity reactions with Dilantin, phenobarbital, and that can be sort of in the setting of dress syndrome or some other thing. So if you get if you have someone who's specifically getting these drugs on your test and they develop fevers, rash, et cetera, that might be a cause of the neutropenia. All right, and then you can also have immune-mediated neutropenia. So this is associated with antibodies against neutrophils or against neutrophil precursors. And it might take several tests to really detect this. You can get increased turnover of the neutrophils as well as decrease of the vascular compartment. The marrow production can be normal to increased, and the storage pool can be normal to increase. This can be a little bit confusing depending which part of the production of neutrophils gets tagged. But I'm going to talk about some of these different factors here in a second. So for alloimmune neutropenia, I'm sure many of you have been driven to the NICU for a consult because of this. So you get maternal antibody against the baby's neutrophils. And this doesn't happen a lot, but 0.2% of pregnancies, so it's not completely uncommon. And this can present with delayed cord separation. It can be really easy to confuse with sepsis because maybe the child's presenting with sepsis. And if you were to do a marrow, you'd probably see myeloid hyperplasia with maturation arrest at the more mature precursors. So once you've identified this as the problem, you're going to just give supportive care. You know, some cases IVIG, and then you can give GCSF for severe infections. So chronic benign neutropenia of childhood is a bit of a wastebasket term, probably caused by several different factors. In some cases, there's anti-neutrophil antibody against the FC gamma R3 antigen, but that's not in every case. This is relatively common. This is when the baby, you know, as it gets closer to 1 year of age, shows up with a low ANC, but looks perfectly fine. And typically the answer is just do nothing, just watch the patient, evaluate and treat any infections, and this will probably get better on its own. But certainly if the patient looks sick, if it's severe or prolonged, you can always do a bone marrow to investigate further. And then there's autoimmune. So really associated with any autoimmune disease or even sometimes by itself, you can target any stage from stem cells all the way through mature neutrophils. This can be, again, associated with other autoimmune cytopenias, with other autoimmune diseases. You can have a really variable ANC. The marrow can look like a lot of different things. So the treatment is going to be to treat the primary autoimmune disorder and to support the patient. All right, so moving on, here we have a pop quiz. We have a 2-year-old with recurrent infections, low IgG, warts, severe neutropenia. So what does the bone marrow show? All right, so it shows, this is a question that I can see getting asked a lot because it's sort of a weird case. I think some of these weird syndromes show up, but then also it's a counterintuitive answer. So you have someone who has neutropenia, why would they have increased myeloid precursors? So we'll get into this in a little bit. The answer is going to be that they have WHIM syndrome. All right, so what are the different, some of the different congenital disorders associated with neutropenia? So a lot of these are primary disorders of myelopoiesis. So cyclic neutropenia, so you get some mutations in the ELA2 gene. And again, this is autosomal dominant, which is important to remember if you're given a history in your test. It encodes neutrophil elastase, and you basically get these neutrophils that just don't, or the neutrophil precursors tend to die off after a certain period of time. So you get these 21-day cycles where the neutrophils kind of come up and go down and come up and go down. And during the periods of the neutropenia, you might get recurrent fever, aphthous ulcers, et cetera. Again, this is highly testable because it's kind of weird. So more severe mutations in ELA2, as well as a few other important stem cell factors, can lead to severe congenital neutropenia. So this is more of a fixed defect. These patients have risk of MDS and AML. Remember, with the WASP gene, you're going to end up with platelet defects as well. And you're going to get apoptosis of myeloid precursors with maturation arrest. So when you do bone marrow, again, you'll see sort of some variability in the precursor populations. So these patients will present with really severe infections. Kostman syndrome is similar, except you also have neurologic abnormalities on top of the congenital neutropenia. And then there's some other disorders of ribosome function where you just have bad bone marrow in general, which is going to impact your neutrophils. So Schwachman-Diamond syndrome. So this is, again, highly testable because you've got pancreatic insufficiency, which is kind of weird. So pancreatic insufficiency plus cytopenias, including neutropenia, are important. And then dyskeratosis congenita can present like quite a lot of different things. So it's important for you to understand the clinical features of dyskeratosis because that'll pop up, highly testable, similar with Fanconi anemia. All right, then we have some other syndromes that are part of granular cytotoxic defects. So Shireki-Higashi syndrome is a mutation in the LIS gene. So again, this is a strange presentation. You have albinism, giant granules in myeloid cells, platelet defects. You can also develop HLH. So this is an important one to remember. Griscelli syndrome type 2 and Hermansky-Pudlak syndrome are similarly can lead to neutrophil defects. All right, so for disorders of metabolism, glycogen storage diseases, sort of the gamut of storage diseases can lead to problems in neutrophils, and they can be both from some bone marrow effects, some intrinsic neutrophil dysfunction, as well as some splenic dysfunction. Barr syndrome is X-linked, so that might be worth noting. And then Pearson syndrome, though, I think is highly worth noting because it's one of the few mitochondrial diseases where they might show you a slide and you can recognize the disease as having mitochondrial inheritance if they tell you it's the mother had it and then the patient has it. So for some immune deficiencies, these will just hit neutrophils along with lymphocytes. I think these are discussed more in other talks, but common variable immune deficiency, IgA deficiency, SCID, in its various types. But I think WHIM syndrome is really important because, again, this is the question I asked initially. CXCR4 mutation keeps the myeloid precursors stuck in the bone marrow, and so that's really a strange presentation, especially with the warts, hypogammaglobulinemia, and then myelokathexis is the word for neutrophils being stuck in the bone marrow. And then another sort of strange one is cartilage hair hyperplasia. All right, so let's talk about chronic idiopathic neutropenia. So there's lots of different mechanisms. So you just have myeloid hypoplasia, you have maturational arrest of the myeloids, and you can have sporadic, which has no specific inheritance. And the impact of chronic idiopathic can be quite variable. This just means we don't really know what causes it, but you might want to look at myeloid dysplasia or autoimmune disease that hasn't been detected. Again, I don't think this is super testable, but just what we call things we can't figure out. All right, so what happens when neutrophils don't work? This is part 3 of the talk. All right, so we have a 2-year-old who has recurrent skin infections, delayed cord separation, abscesses that lack pus with poor wound healing, and elevated ANC. So you have increased ANC, but things just aren't working. So what's going on here? So again, this is a highly testable question. And the answer is the CD18. Remember, the beta-2 integrins all require CD18. So leukocyte adhesion deficiencies. So with leukocyte adhesion, you make plenty of neutrophils, they just don't work. So they don't stick to the endothelium. They can't target the germs. Their mechanisms are really dependent on functional beta-2 integrins. And so in these patients, again, you'll see either normal or increased ANC, but things just aren't working. And you might see this in the NICU when the umbilical cord doesn't separate. You have early and recurrent bacterial infections. They don't make pus. You have impaired wound healing. Again, you have leukocytosis. In these cases, also important that, a test question might be, what do you do? The answer is not to give GCSF or GMCSF. It won't be helpful. So the different types of leukocyte adhesion deficiencies, there's 3 main flavors that you might get asked about. So leukocyte adhesion deficiency 1 is going to be autosomal recessive with a CD18 that I just mentioned. Leukocyte adhesion deficiency 2 is one of those things that you might see in your boards, but probably never in real life. There's been like 10 cases reported of LAD type 2. It's not as severe as leukocyte adhesion deficiency type 1, but it, with respect to the neutrophil defect, but that basically you're unable to create the carbohydrate modifications required for the neutrophils to work, and that's also required for a lot of other processes. So these patients have really quite a broad spectrum of problems beyond their neutrophils. But again, only 10 patients have been reported. Another reason why this might be important is because it's associated with red blood cells that have no H antigen, which is called the Bombay phenotype. So again, this is strictly important for boards, probably not for your actual practice. And then leukocyte adhesion deficiency type 3 is a lot like type 1, except instead of not being able to make the integrins just don't get activated. And so we can see here the different types. So again, the beta-2 integrins, either you don't make them or they don't work. For leukocyte adhesion deficiency type 2, you're just not making the carbohydrates that you need in order for diapedesis to work. All right, then we have our degranulation defects. So I just talked previously a little bit about Shirakashi syndrome. So this is a problem where we have defects in membrane fusion and lysosome trafficking. So you basically just make these giant leaky granules that are ineffective for phagocytosis and for killing the phagocytosed germs. Some other things to remember is that these patients can have oculocutaneous albinism, giant granules. If you're given I think a path slide of Shirakashi is quite common. And then they can also develop HLH, especially in the setting of Epstein-Barr virus. And then you can have specific granule deficiency. So remember, I talked about all the different types of granule formation. So you really need this transcription factor. That's also important in AML, but the CEBPs are important in the maturation of neutrophils. And it's required for expression of specific granule proteins. And so if you're missing, or if you have a dysfunctional CEBP protein, you're going to end up with neutrophils that don't work. So you'll have decreased chemotaxis. Importantly, you'll have these bilobed neutrophils, and then you'll get recurrent skin and tissue infections. Certainly the diagnosis here, you'd probably be given a slide where you're given this history. All right, so this one, money back guarantee. I guess ASFO doesn't have insurance for this, but you will be asked this question or some form of this question on your boards. So this child has recurrent granulomatous infections. This is the mother's DHR test. So what's the gene defect? So we're going to get into this, but it's really important to remember the GP91 mutation is associated with X-linked chronic granulomatous disease, and it's the most common. And it's just really testable because the others are all autosomal recessive. And it's also important that you can understand how you diagnose CGD from lab assays. So remember we talked about this oxidative process being required for neutrophils to work. And so if you have dysfunctional oxidative function, you're going to end up with dysfunctional neutrophils. And so what happens then, you're sort of ingesting these, you're going to go ahead and ingest these germs, but once you ingest them, you either have no acid or not very effective acid as far as the killing process. And so you end up with this clinical course of recurrent infections in the skin, lung, and lymph nodes. Abscesses are really common, again, because you're sort of able to grab the germs. You just can't then kill them very effectively. So you have a lot of weird infections associated with CGD, including Aspergillus is frequently tested. Burkholderia is another one that's a little bit strange, but shows up in these patients. And so how do you diagnose this? So it used to be the nitroblue tetrazolium test, where you basically incubate the cells with this kind of a litmus test, and would go from yellow to purple from the activated neutrophils. Now we have this flow-based DHR test that's a little bit more accurate, and it's sort of a version of what I showed previously, where you have either an early peak for dysfunction. Give an early peak or a late peak, depending on how functional the cells are. And so if you have 2 peaks, that'll be a mother who has half dysfunctional DHR and half functional DHR. Also, I think more and more now we're diagnosing these patients through whole exome sequencing. So treatment is going to be prophylaxis, as well as giving some interferon gamma to enhance the non-oxidative phagocytosis. All right, then you can have myeloperoxidase deficiency. So this is going to be the myeloperoxidase part of the phagocytosis and oxidative metabolism reaction that doesn't work. This usually isn't a problem unless the patient has diabetes. So if you're told a patient has diabetes and develops these infections, you would say you might want to look for an MPO deficiency. And there's some miscellaneous ones that you might want to look into. So G6PD, RAC2 GTPase has been reported. Again, it's really required for chemotaxis as well as oxidative burst. And then IRAK4 deficiency could be tested. This is associated with NF-kappa B activation. So that's the association that's important. All right, so now we're going to move on to other myeloid dysfunction, kind of moving beyond the neutrophil. So, if things are broken up here, it's sometimes not just the neutrophil that doesn't work, but the entire spectrum of diseases. Again, most of the macrophage dendritic cell disorders are going to be covered elsewhere, but we'll just talk about a few of these things. So if you have impaired macrophage function and atypical mycobacteria infections, it's sort of classic for having interferon or interferon gamma receptor mechanism not working, because these certain infections, in addition to atypical mycobacteria, tuberculosis, as well as histoplasmosis, are associated with interferon gamma. So it'd be really important to think about gamma-mediated defects in such patients. And then there's hyper IgE syndromes, again, very testable, especially the STAT3 mutation, which is associated with Job syndrome. And then you also have your autosomal recessive hyper IgE syndromes. And what these have in common are defects in JAK-STAT signaling, impaired cytokine responses. You end up with defects in neutrophil chemotaxis. But then the part of making more IgE than you should is really what characterizes or separates these conditions from others. So if you have a patient who's just covered in sores, remember this is called Job syndrome because Job was the poor soul in the Bible that Satan covered with boils. And so if you have a patient that's covered with skin lesions, has abnormal teeth, and facial features, really think about hyper IgE syndromes and specifically STAT3 mutations. All right, so for a pop quiz, you've got a 1-year-old who's losing milestones, develops hepatosplenomegaly with cytopenias. What does this image show here? And this is going to be Gaucher's disease. So again, many storage disorders can impact bone marrow function because of infiltration of the bone marrow, as well as just some of the intrinsic functions of the cells. In the case of Gaucher's disease, you have a glucocerebrosidase defect. I think this is just a fairly testable disease, even though it doesn't typically have a huge amount to do with hematology. It's a bit of a red herring where sometimes we'll see patients with big spleens and livers, abnormal bone marrows, who have a late presentation of Gaucher's disease, especially without the CNS involvement. And it's important to recognize that the sort of accumulation of these cells over time can lead to bone marrow dysfunction. And this is also very treatable with enzyme replacement. So that's another reason to remember it. So neutrophilic leukocytosis, most frequently it's going to be just a left shift. So if you have someone who has an ANC of 20,000, read the rest of the story and probably they're just going to be infected. But it can also show up with autoimmune disease. Importantly, steroids can cause mobilization of stored neutrophils. So if there's a test question where someone gets a huge slug of steroids and their ANC goes up, yes, they could be infected, but could also be glucocorticoid induced. And then basically other forms of stress will cause mobilization of your neutrophils. But you also have to think about myeloproliferative disorder. Sometimes increased neutrophils can be a harbinger of chronic myelocytic leukemia, JMML, other malignancies. Also in Down syndrome, if these patients end up with transient myeloproliferative disorder, that's something to remember. And then you can have genetic disorders, as I mentioned, leukocyte adhesion deficiency can also cause too many neutrophils. Frequently, it's just lab error as well, so it's important to repeat the test. So if you have monocyte leukocytosis, this is your absolute monocyte count is increased. Again, this is part of just bone marrow getting revved up for acute phase reactants, can be part of acute bacterial infection or tuberculosis, but it can also be it's classically associated with EBV. So if you see a huge monocytosis, think about EBV, because that's a very testable question. And then basophils, I can't imagine a question about basophils, but they're part of the lineage as well, the myeloid lineage. And so if you have increased basophils, what are things that can cause increased myeloid production in general? So eosinophilic leukocytosis, I think, merits a little bit of specific mention. So if you have too many eosinophils, or this can be the too many parasites, right? And the parasites stick around and you haven't figured it out. But if you have really elevated eosinophils for a long period of time and you haven't figured out why, it's important to remember this can be caused by problems with the stem cells. This can be part of a myelodysplastic syndrome. It can be associated with various fusion events and also myeloid leukemias. Most often it's going to be secondary or reactive in kids who are sort of have allergy, atopy, parasites, et cetera. And then also remember DRESS syndrome, so drug reaction with eosinophilia and systemic symptoms. It's important to, I think, just keep that syndrome in the back of your mind because it can hit a lot of different test questions. Then something we're realizing about dendritic cells. So dendritic cells were discovered in the 70s as a separate cell lineage that has some similar features to macrophages as far as being an antigen presenting cell, but they actually are able to activate T cells much more effectively, and they have different kinds of ontogeny. And I think this is important as we look at different diseases like Langerhans cell histiocytosis. I think Dr. McLean will talk about this a little bit, but we have these tissue resident dendritic cells whose job it is to kind of be the sentinels of the immune system. When germs come up, they get engulfed and you present the antigens to the T cells within the lymph nodes. But the way these guys get here is really complicated. They can come from fetal liver or yolk sac during embryo. They can be replaced by monocytes, or they can come from specific dendritic cell precursors. I don't think this is going to be super testable, but it's just, I think, important as we understand where do these cells come from, how are they replaced, what's the homeostasis that underlies the tissue resident macrophages and dendritic cells. I think the most important thing is recognizing that dendritic cells are supreme antigen presenting cells for T cells. They do that more effectively than macrophages. So I've just mentioned that here, so I'll just skip over this slide. Again, there's lots and lots of conditions. We have too many myeloid cells, so myeloproliferative disorders, histiocytic disorders, these are covered in other presentations. But it's really important to think about when you see too many monocytes, too many neutrophils, could this be part of a broader syndrome? So not enough myeloid cells is a little bit less common, but we're recognizing a few conditions where this happens. So GATA2 deficiency has received a lot of press over the last 5 years or so, I'd say. And I think this is one to definitely spend a little bit of time to remember. So it's been associated with what we call monomax syndrome. So the interesting thing about this is it's an immune deficiency, but it's an immune deficiency that doesn't typically show up until later childhood or even early adulthood. People can have no absent monocytes and not have obvious infections for quite a while, but ultimately they can be susceptible to mycobacterial infections and some other conditions. So I would just say read the slide and make yourself familiar with GATA2 deficiency. All right, so here's a couple bonus questions just because they're testable, not necessarily because they're super related to this talk. So what is this condition? So you've got sort of a strange looking neutrophilic precursor here, and you've got a really big platelet. So is it, which of these is it? The answer is going to be May-Hegland anomaly. So just remember Dolly bodies, which are these strange inclusions in myeloid precursors, as well as large platelets are going to be part of the May-Hegland anomaly. All right, just thinking about splenomegaly. Splenomegaly can show up as part of I guess the tip of the iceberg of a lot of different things that are going on. When you have a big spleen, just think about what are the different potential causes. And this is, again, highly testable. Infection, malignancy, lymphoproliferative disorders, hemolytic anemias, whatever is going to block up that spleen. But also it can be liver disease, right? If your plumbing is blocked up, it can sometimes show up in your spleen. Storage diseases, space occupying lesions. So it's really important to understand, is the problem intrinsic to the spleen? Is it the spleen in the liver? And if it is the spleen, what else, what exactly is going on in the peripheral blood, doing a peripheral blood smear. So doing a history and physical, CBC, retic with a smear, LFTs, EBV, and chest ultrasound and X-ray are helpful. I think PET scan is helpful if you can get it, or if you think it's warranted. So again, some bonus slides we talked about a second ago. I showed you the May-Hagelin anomaly. There's also the Pelger-Hewitt anomaly. This is autosomal dominant. You get the dumbbell hyposegmented nuclei and mature neutrophils. This can be acquired with leukemia or MDS, but I'm going to show you the slide here in a second. The May-Hagelin I showed you is also autosomal dominant, results in thrombocytopenia, big platelets, inclusions in peripheral blood leukocytes. Then you have a whole spectrum of diseases sort of associated with the May-Hagelin anomaly as well. So for homework slides, I would say make sure you check images of neutrophil maturation, Shirakashi syndrome. Make sure you can recognize secretory granule deficiency, Pelger-Hewitt anomaly, May-Hagelin anomaly, and Gaucher cells. I think those are helpful as you go through your path review. For a bonus slide, we'll talk about autoimmune lymphoproliferative syndrome, or ALPS. Again, this isn't really what I'm talking about, but it's so highly testable. I just want to make sure that you have another chance to think about ALPS. You get, this is a defect where your lymphocytes simply don't die. And so you end up with increased double negative T cells. Again, it's caused by sort of defects, in either inherited or acquired defects in some of these apoptosis regulating genes. Also, RASopathies can be associated. You can get autoimmune cytopenias, elevated B12 for reasons that I don't completely understand. And then your treatment's going to be sort of blocking the mTOR pathway. And Kennedy Rao will take you, please don't take the spleen out because you have a much higher risk of death. All right, so that was sort of a quick survey of what I think are the most testable aspects of leukocyte biology with specific focus on granulocytes. I hope that the slides are helpful. If you have any questions or suggestions for improvement for future talks, please feel free to contact me at my email here. And I believe we'll have a chance to answer your questions in person during your actual session. But good luck. Remember, this section is not super heavily tested, so I would try to understand the larger concepts and really focus on some of the points that I've highlighted here. All right, thank you so much.
Thanks, Dr. Allen, for your excellent review and talk. And for the record, I will attest that you can miss all the questions about neutrophils on the boards and still pass. Okay. Carl has actually done a great job of answering questions live. Certainly, if you have new ones, please type them into the Q&A box. But we'll, for the benefit of everyone else, let's go over some of the ones that were talked about. Can you talk about the differences between GM and GCSF and the usage?
Yeah, sure. So GM-CSF and GCSF are both growth factors that kind of play a role in determining how myeloid precursors kind of get skewed as they make their way through the bone marrow. GM-CSF targets a bit of a broader range of cells, kind of supporting monocytes and other myeloid cells. I think, I'd have to really look into the history of why we've really focused on GCSF. I'm not sure if there's pharmacologic reasons why that drug became more widely used. I think we can hand wave and say we try to stay away from GM-CSF a little bit because there are GM-CSF receptors on some cancer cells where GCSF is more specific to neutrophils. So if you're really just trying to target neutrophils, I think that's what's led to that custom. Certainly in bone marrow transplant, sometimes when we really want to see if there's anything left in bone marrow function, we'll give GM-CSF or both. But again, I don't think there's any data really supporting this. And in fact, I think it's pretty controversial if GCSF is helpful at all. I mean, we can debate this as far as clinical practice, but for terms of the boards, I would just be aware that GM-CSF and GCSF are both required for neutrophil growth and that GCSF is a bit more specific.
And to tack onto that question, the role for GCSF in cyclic neutropenia, that one just came in live.
Yeah, sure. So again, I think that's this is a kind of a clinical question. I don't think this is going to be really tested on your boards. And I think for cyclic neutropenia, it just depends on, you know, if there's an infection or if there's a problem. I think if someone has cyclic neutropenia but doesn't have any clinical symptoms, usually you just let it fly. But for patients where they do need their neutrophils to be supported, GCSF can be helpful because it is, you know, sort of this hypofunctional mutation in neutrophil precursors where GCSF, in this case, could be helpful.
Excellent, thanks. Okay, there were a series of questions about altitude and neutropenia, which if you actually looked at the sample questions, it was one of the red herrings thrown in on one of the leukocyte questions. So do you think it actually has anything to do with the altitude, or is it more a genetic or benign ethnic neutropenia based on populations that live at high altitude? What is your theory?
Yeah, I mean, I have to admit, I'm not completely, I haven't done exhaustive literature search on the rationale for this phenomenon, though it's a well-documented phenomenon that, for what it, you know, it's sort of cute, so it shows up on tests. So yeah, I mean, I think that would be a fascinating research project to, I don't know, maybe compare RNA-seq on bone marrow stem cells in Denver versus Houston. But I don't. Again, I'm not completely sure what the reasons are. I think there has been some research done on it in space. Anyway, this is all well beyond the 4% of what you need to know. But I would just say that the point is recognizing variations that aren't disease. So, for example, different ethnic populations having different baselines, you know, different environmental conditions, giving you different numbers that aren't pathologic. And then again, I think as far as pathology, just recognizing the left shift or the reactive bone marrow, you know, the neutrophils going to do their job is going to be by far the most common cause of neutrophil activation or increased numbers. And then also just general bone marrow suppression from viruses is going to be your most common cause of neutropenia.
Okay, great, thanks. Let me skip down to a couple questions about testing anti-neutrophil antibodies and autoimmune neutropenia. I guess questions popped in about the role of when or what patients you might actually send it an anti-neutrophil antibody test. And then also another question came in about, you know, what do you do when these patients have fever if they're labeled with the disease?
Sure. So for the first question, it's sort of, you know, you imagine you're called for a consult and someone's got neutropenia. And I think one thing that's not great about these lists or like up to date is, you know, you're not looking at, I'm kind of putting everything out there. And so like there are a few questions about why would you test al-Nafis, et cetera. I mean, I think that the tests you get really depend on clinical context, right? And so I think if you're in the NICU and you've got a kid who's got delayed cord separation, you might think, okay, well, this is pretty unusual. And I think that, you know, either maternal antibodies are a pretty reasonable guess as to why that's happening. So you might test that first thing, right? But if you're seeing someone on the floor who's a teenager, who's otherwise healthy, I think it would probably take you a while to kind of say, well, okay, well, let's exclude autoimmune disease. And you know, if there were other sort of signs of, you know, lupus or some other autoimmune disease or other kind of possible immune cytopenias, you know, from that you might get a clue from the marrow, maybe you would test at that point. But so again, I think it's a tool in our toolbox when we're thinking about autoimmune causes of neutropenia. You would want to test it. When exactly you do that would kind of depend on the scenario.
Sure, and I'll expand on that one other kind of semi-related question that came in. So what do you think about actually treating like fever with some of these patients who have viral or presumed viral transient anemia? I'm sure all of us have admitted 11-month-old toddlers with obvious viral syndromes, and they wanted to admit to HEMOC because their ANC was 350, where everything else was normal. Do you have thoughts about those patients?
Yeah, those are tricky, right? And I think like there was one question about, well, what, you know, if you have an established diagnosis of cyclic neutropenia, or if you have an established diagnosis of autoimmune neutropenia, I mean, you can kind of take a guess as to whether, you know, what your reserve is, what your ability to mobilize neutrophils is. You're not concerned that it's cancer, right? And so I think again, you can kind of take the whole clinical context as far as whether you admit them for more evaluation or not. So yeah, I can't really give a blanket answer on that.
Sure. Okay, great. Thanks. We're doing pretty well on time. Questions came in about cyclic neutropenia. I mean, the textbooks say that all your blood cells cycle to some degree, but so do you actually see lymphopenia or other like obvious cytopenias when with the neutropenia?
Well, so for classic cyclic neutropenia, it's a pretty specific neutrophil defect, I think, which is what makes it kind of unusual. I think if everything was sort of cycling, you might look at more sort of bone marrow failure or other kinds of questions. But yeah, again, I think you take it in clinical context, but it would be unusual to have lymphocytes cycle with the neutrophils.
Okay, thanks. Let's go down to a question about, you mentioned that patients with Kosman and HAX1 have neurologic abnormalities. What kind of things do you see?
Yeah, I mean, so in preparing for this, I was kind of looking up, I've never seen a patient with Kosman, but there's a couple of clusters of families reported. This is only a handful of cases, right? And there's variable amounts of neurologic defects from none to severe, but it's typically, I think the mechanism is sort of a shared sensitivity among the hematologic cells as well as cerebellar kind of sensitivity to apoptosis. And so, yeah, it's just kind of variable, but I would just note that if you get any question that says someone has seizures or they're losing their milestones, I would just let that be a trigger for this question.
Okay, excellent. Next, can you go a little bit more about the DHR test for CGD and like which peak is what and what do you see?
Sure, yeah, sorry, I didn't explain that, but I kind of mumbled through that in the talk. So when you have effective oxidative burst, when you're doing the flow, if you don't stimulate the cells, the peak will stay on the left. You stimulate the cells, you should get an oxidative burst from healthy neutrophils that will shove it right. So if you don't get it shoved right, then that would be a concern for defective neutrophil function. And the reason you have two peaks in a mother, right, is because of lionization. Half the neutrophils are doing the work and half of them aren't.
Excellent.
And so yeah, that's sort of the standard of care now, is to do the DHR test, although I don't know, like different at different sites. Now I think people who are under suspicion for CGD, it seems like the genetics test comes back faster in some cases.
Thanks. And NBT is definitely not on the boards anymore. That was like 20 years ago.
I'm sorry? Oh, I don't know. I mean, probably not. I would be aware of it, but
no, I remember when my last research of the boards for a leukemia question, they said your flow cytometer is down. Which of these special stains might you see in AML? And thankfully they got rid of those questions, because if your flow cytometer is down, you send it to a different lab that has a flow cytometer. That's the answer.
Yeah, I mean, I think that's a good example too. Like the point isn't necessarily to memorize every single fluorochrome, but to say, okay, well, you're trying to measure oxidative burst, so how would you do that? You can probably reason your way through the question.
Okay, let's see. Let me go to some of the open questions. Can you talk about the differences between DOC8 and STAT3? And are there clinical differences? And do you think this is relevant for boards as well?
It could be. It could be. I would recognize the differences in inheritance, whether it's autosomal dominant or autosomal recessive. But I don't think you're going to be asked to recognize the differences, among these sort of related conditions. More, I think that just recognizing that if you have a patient that seems like Job syndrome or has any of the related features, to think about that class of mutation.
Okay, and for the dumb oncologist like me, those are both genes associated with Job syndrome, correct?
Well, yeah, I think more specifically with hypereosinophilic syndromes in general, but I think the STAT3 is more typically sort of the more severe.
Okay, excellent. Thank you. We're still okay on time. So another cyclic neutropenia GCSF question. So if you have a patient who has cyclic neutropenia and they get severe enough infections where you think treatment is warranted, what type of schedule do you personally recommend of the GCSF?
Yeah, so I would have to admit that I would have my colleagues in the cyclic neutropenia clinic manage this patient. I'd have to just go to the literature to see what the most recent evidence-based guidelines are. I think for the purpose of this test, it would just be a question of understanding that sometimes GCSF can be supportive in this condition. Again, I don't think you're going to get asked about which regimen to use.
Got it.
I just don't want to give an answer because I think my practice may be a little out of date.
And say if the insurance company says you have to use Neulasta, do you think that would be appropriate in that situation? Or would you defer?
I don't know. That's a good question. I mean, I'm not sure what insurance is doing with it. Again, I haven't personally treated this for a while, so it seems like the timing would be shorter. The timing of neutropenia would be shorter than maybe you need from Neulasta, and you want to be able to react to it. But again, I'm not going to give specific recommendations on this aside my.
Sure. No, I know. Certainly for oncology patients, sometimes what growth factor you choose is whatever growth factor the patient's insurance company chooses. And it's sometimes not worth the fight to do something different. Okay, let's see. Another questions came in about Pelger-Hewitt anomaly, and there were some also about the bilobe neutrophils.
Right.
Can you talk about like the differences? Are there differences in the morphology of a bilobe neutrophil in Pelger-Hewitt versus granule deficiency? And also, if you have Pelger-Hewitt, are there symptoms or diseases, signs that are associated with it?
So yeah, thanks, Robin, you for asking me this question. I hope you're doing well. Anyway, the way I think about this is very simplistic, just to say, like, if you have sort of really bad bone marrow, it's going to spit out all kinds of crazy shapes, and you can kind of see the stress in the marrow when you start seeing like bilobes, nuclei, things like that. It means that the bone marrow is not really working normally. And so beyond that, I would really focus on your heme path review. We're going to go through each of these different things. I mean, so there are different conditions where you have this bone marrow stress, or maybe it's even just sort of some idiosyncratic part of your bone marrow function. So for Pelger-Hewitt, for example, it can be developed, it can be acquired, right? Not just inherited. And you can sort of see this in some cases of like MDS, again, where your bone marrow is starting to function not quite right. I would say for specific granules, you should be able to see those under the microscope. Like, could I see it if I was shown, out of the blue? Probably not. If you're shown two different slides next to each other and one of them sort of is lacking the granules, you might be able to see those. And I think these questions, this is a bit more specific than I would predict you're going to be asked, but it is possible. So I would say that when you go through your heme path section, I think you guys still do a review, like a picture review. Be sure to ask the heme pathologist about these nuances. I found that session to be really one of the most useful when I was preparing for boards.
Excellent, thanks. And in terms of the Pelger-Hewitt, I mean, as a hematologic malignancy specialist, which is my area, no, I definitely think you can see Pelger-Hewitt, one-eyed eosinophils in AML or MDS-AML, and I rarely see it in ALL. And I just kind of always think, okay, that means that something's messed up with your myeloid system, but I don't think it's as specific as the textbooks necessarily.
Yeah, and I'm not sure there's any functional defects associated with it. Again, it's one of those things where it's a strange name, it's a weird shape. It sort of reflects some basic features of hematopoiesis and myelopoiesis to be aware of. So I think that's why it shows up.
Okay, let me go to question popped in. So if you have an infant that has sepsis and severe neutropenia, is there a way to quickly determine SCN versus Kosman on the clinical presentation? or are there hints on a board question how it would, or do you really have to look at the genetics?
I think the genetics is the most, probably the, in these days, the easiest, but I would say on the boards that I would say, what are other symptoms, other neurologic defects or not, would be sort of the clue.
Excellent, thank you. A couple, which are more comments than questions, but a comment from Dr. Warrior, just as a warning about lack of guidelines, that he was called as an expert witness for a child who had cyclic neutropenia, who died of an infection, and the treating physician was sued. Again, I don't think there are clear guidelines, and it is somewhat subjective, but then it's just a reminder, document your discussions, pros and cons, everything like that.
Yeah, thanks for sharing that.
Okay, and then another post was that there is an international chronic neutropenia registry that actually patients can get free GCSF through the registry. I was unaware of it, but the link is in the Q&A section if anyone is interested in that. I would assume that registry is likely sponsored by a maker of a GCSF project. Okay. Oh, actually, I wasn't looking at the chat box. Some questions went in the chat box.
Okay.
It was more a comment back to high altitude. I guess there's literature that suggests that ANC can be elevated at high altitude in NICU babies, and they think it may be relative to hypoxia. And
that would make sense.
Yeah. So I don't know.
So do I have a reference? I mean, so my reference of the phenomenon is more it's kind of review clinical descriptions of the differential diagnosis of neutropenia, not so much mechanistic studies of why that happens.
Okay. And Mike, thanks. If you can send or post a reference, that would be great. I know during the talk I did a quick literature search, and there's not large, high quality evidence in terms of series about altitude and neutropenia. Okay? So if anyone here wants to tackle something and happens to be in a high altitude center, has friends in low altitude centers, go for it.
I mean, I would categorize this sort of in the area of medical trivia, right? Like not every African-American teenager is going to have an ANC of 900, but if you see an ANC of 900 in an African-American teenager, your suspicion that this is pathologic might be influenced by understanding the patterns, right? I would say the same thing for, I don't know if there's anyone here from Salt Lake City or Denver to comment on this, but I'm sure your threshold for investigating ANC is pretty similar to.
Sure. Well, I know Mike was in Utah, but now he's in Virginia. So we have time for pretty much one last question, which just popped in, which I like this question. So do you routinely test for Duffy antigen in suspected benign ethnic neutropenia? Or do you just say, or do you make the diagnosis clinically without a test? What are your thoughts about that?
Yeah, that's a good question. I think if you're suspecting benign sort of ethnic neutropenia, it's sort of more excluding other causes than proving it, right? And so, yeah, I can't say I've ever ordered that test. I don't know, Glenn, if you.
I know I have ordered that test in a bunch of oncology patients with ALL who always are neutropenic, and we have a large African American population that we treat in Atlanta, and I don't know. I mean, I'm not sure how helpful it is because our patients where the test was negative, but they still always had disproportionate neutropenia and everything else was fine. We still said, I bet you have benign ethnic neutropenia. And I know for some of those patients, we just use different parameters for their adjustment of chemotherapy or when they would start. That if everything else was good, I don't care if your ANC is 300, you look great, everything else has been perfect, and we forged ahead. And I know I've had a small handful of those patients, and none of them ever had any problems with infections. Okay, I go back to the script. Okay, so I think we are done with the questions. Well, that's all the time we have. So thank you very much for attending this session. Thanks again, Carl, for the excellent talk and discussion. So the chat and Q&A are now officially over. Please watch for further details regarding virtual office hours in late February or March for an additional opportunity to ask questions and interact with our speaker. And then also don't forget, you can visit the launch networking chat button in the top right corner of your session logins. And then if you set up a chat profile, you can connect with your peers during the breaks. The next session on retinoblastoma, germ cell tumors, and hepatoblastoma will begin at 11 a.m. Central. So please exit the room and join that sessions room at the appropriate time. Enjoy the rest of the course, and everyone have a good day.